So I thank you for joining Elder Abuse Ontario for our part 2 series on how do we get to safety planning. Our topic today is understanding and responding to responsive behaviors to support older adults and their caregivers. So I'm very fortunate today to be joined by Sudha Valvila, who is the team lead for the BSO Clinicians Community Intensive Care Management from the Alzheimer's Society of Brant, Haldeman, Norfolk, Hamilton, and Halton. We also are joined by Judy Wheeler, who's the manager for the First Step program and the Vulnerable Seniors team lead from CMHA Waterloo Wellington, as well as Kathy Sturdy-Smith, who's the manager of specialized geriatric services from CMHA Waterloo Wellington, and also their colleague Laura Sullivan, who is the Seniors at Risk clinical consultant with CMHA Waterloo Wellington. So if you are just joining us and your phone isn't muted, I just ask that you mute the phone until we begin. So we are just a few logistic questions before we do begin. Everyone should be muted on the phone, and I'll be monitoring that just to make sure there's no background noises. If you do have a question, you can put that into the question box at the bottom, and I will try to answer that. So on the right-hand side of your panel, there should be a question or chat box. So if you want to ask a question during the presentation, you can put that in there. Depending on what the question is, we may do it now or may wait until the end of the webinar to answer those questions. There will be time allotted at the end, so you can we'll have time to ask the presenters for those questions. Also at the end, you'll be prompted for an evaluation just to complete, won't take more than 5 minutes. So we do appreciate your feedback on that if that's possible for you to do. And the contact for the presenters will be provided. There is also the PowerPoint I've loaded on the materials section. You can load that now, but also the webinar will be posted after the webinar next week onto our website with both audio and PowerPoint as well. So if you need to access that, you can do so then. So as I mentioned, as you know, the presentation is about safety planning today. And just to bring to light one of the impetus of doing the safety planning webinars is that we did develop a safety planning toolkit in 2007, and we have recently adapted that to include issues around planning with individuals with cognitive impairment. And we were pleased to work with the Alzheimer's Society of Ontario, who also we worked with the Law Foundation of Ontario and MetTrack as well to get their input in terms of their advice and making sure that this was accurate information in regards to both law and respect for violence against women. So just our learning objectives, many have seen this in our promotion, but really we want to understand what the role of the BSOs, or Behavioral Supports Ontario, is in terms of responding and supporting to older adults with responsive behaviors and their caregivers. Gain a little bit more insight in terms of responsive behaviors versus the difference between coercive control, and also becoming familiar with what tools BSO uses to assess risk in safety planning and approaches to supporting individuals. And then we're going to shift with our other presenters to learn more about collaborative team approaches and how we're supporting older adults who are living at risk to optimize their functioning and quality of life, and become aware of safety planning options that they're using within their organization to support older adults with dementia and their care partner, and interventions to maintain wellness. And they're also going to highlight the Safe Pathways project that has been in place for quite some time. So just for those who are just joining us maybe for the first part of this first webinar, just to give some people background of Elder Abuse Ontario. We are a nonprofit organization, and we're funded through the Province of Ontario Ministry of Seniors and Accessibility, and our mission really is to make sure seniors are free from abuse and treated with respect and dignity. So we were given the position to implement the Ontario strategy in 2002, and we've been doing that ever since. And that strategy encompasses 3 main priorities that we continue to do today, which is coordinating community response, We do training to frontline agencies and organizations, and we do a lot of public education and awareness. There are 7 regional consultants in the province, and one of the roles and mandates of our group is to support older adults in the community in terms of doing education and training, but we also support local elder abuse networks, and we do a lot of outreach and education, and we do a lot of webinars, as many people may have already have been joined in previous ones. So we have 7 consultants. These are the locations that we are located in. We have 2 francophone consultants as well. The one thing that we don't do as consultants is case consultation in terms of case management piece. So we help people navigate the system to try to find assistance, but we don't do an actual case management of each individual case within the province. We work with our community partners who have that capacity. So it's really important in terms of your participation, and we commend you for being involved, because we do recognize that there are specific skills that skill set in terms of recognizing abuse, and not everyone is quite familiar with that. So our webinars really do help clarify what those signs and rules are, and today we're really going to talk about risk factors and what those red flags can be, and what tools you can use to support older adults that you may feel are living at risk, and develop those safety planning for the individual and their caregiver. So just in terms of safety planning, one thing to take into consideration is knowing, the differences between violence between intimate partners, elder abuse, and family violence. And really, if you look at the main differences, is who the potential perpetrators are, and that would be more intimate partner, obviously a spouse or a partner that they're living with, but the elder abuse includes grandchildren, nephews, nieces, etc. I'm just wondering if anybody else is having sound problems, because I am getting a couple emails in regards to that. If you are, could you please put your response in the chat box, and I'll see if I can look into that after we go through introductions. Sorry. So the one thing to keep in mind, and I know our presenters will be talking about, is the rights and respect and autonomy of our older adults. So that's one thing that we, as Elder Abuse Ontario, respect in terms of our guidance, is that, giving older adults the autonomy and the right to make decisions, and based on their ability or capacity to, if they're capable, that they have the right to live at risk, although I know our presenters will talk about that in a little bit more detail. But we do have guiding principles that we do recognize as well for older adults, and respect those. So our safety planning toolkit is on our website, and you can download that under our tools section. If you go under training and it's under our tools, you will be able to find that there. So without further ado, I'm going to introduce our presenters. So our first presenter is Sudha Vilva, and she is the team lead for the BSO clinicians and community intensive care management with the Alzheimer's Society of Brant, Haldimand, Norfolk, Hamilton, and Halton. So quite a large regional geographic area. She has her professional research interest is in dementia and mental health, and she has more than 11 years experience in global multicultural work experience in social services, mental health, healthcare, voluntary organizations, not only in Canada, but also US, England, India, and Switzerland. And she's passionate about developing and reaching out to provide culturally and linguistically appropriate services for a person-centered approach for people with dementia and their caregivers. So thank you so much for coming today to share your knowledge and research with us today. We're also joined by the team in Guelph, which our first presenter or group is Judy Weiler, and she is a vulnerable seniors team lead for CMHA in Guelph, Wellington. And Jody has worked in the field of geriatrics for over 20 years, and she has a BA in sociology and anthropology from Carleton University, and also a BA in gerontology from Guelph, as well as a MSW and RSW from Laurier University. She's also worked as a place coordinator for the LIN, Homeward Healthcare Center in Guelph for the programs for older adults transitioning into long-term care and community. In her previous role, Jody worked in the specialized geriatric services at mental health social work clinician, where she completed a comprehensive mental health assessments and worked with geriatric psychiatry, geriatric medicine, acute care, community partners to support and coordinate services for older adults. Someone can just turn off their webcam. It just came up. Thank you. And Kathy Sturdy-Smith, who's also part of the team. Kathy started her career in seniors supporting families, caregiving for relatives with dementia and other related neurocognitive disorders in the adult day program setting. Over time, and in working with a number of organizations, she expanded her work and clinical role to include seniors with addictions and mental health issues in both community and long-term care homes. Kathy's responsible for the leadership of the specialized geriatric outreach mental health program at CMHA in Waterloo, Wellington. And she works along with her colleague Jody as well. And lastly, Laura Sullivan, who also is the Seniors at Risk Clinical Consultant with the Specialized Geriatric Program. And she has been there for several years and has been on the team since 2001. So I am going to turn the presentation over to Sudha, who will then talk about the BSO community team. And I'm going to continue monitoring questions. And if anybody has any, just please put those into the question box. So Sudha?
Thank you. Thanks, Rayanne. And good morning, everyone. I'm Sudha Vavilla from the Alzheimer's Society of Brant, Haldimand, Norfolk, Hamilton, Halton. And I'm here to talk about responsive behaviors and in the context of these following learning objectives. And I'm hoping that by the end of my session, it would cover the following objectives, including being able to know and understand what responsive behaviors are, the role the BSO team play in supporting clients in our LIN, and the BSO tools that we develop to assess, leading to a behavioral care plan and provide intervention. So to make this an edge of the seat thriller, I'm just joking, we have a poll question coming up. So if you could all answer the question, which says persons affected by dementia will react to the symptoms of their illness through observable behaviors or emotional response. If you could choose an option within the next 5 seconds, that would be great. And click submit. I'm hoping you've done that now because I'm going to ask Rayanne to go for the results.
There's a few more people just responding, so I'm just trying to see. We have about 78% that's responded. Some are on phone, so they won't be able to respond. So I'm going to close the file and then show my screen. So the responses, 83% said yes and 17% said no.
Awesome. So as you know, any behavior is a means of communication. So a responsive behavior reflects a response to something negative, frustrating, or disorienting in the person's environment, which can also be a protective behavior. So some behaviors are adaptive, others cause difficulties for the person living with dementia or the caregivers or any other persons that the person may interact with. Next slide, please. Rayanne, can we move to the next slide?
It's common terminology?
Sorry?
Do you see the slide, common terminology?
No. We are still stuck at the poll question.
Oh, okay. Sorry.
Can you go back a bit? I think it advanced a couple of slides further. Yeah. So when we are looking at responsive behaviors, we are referring to a term that represents how their actions, words, and gestures are a response, often intentional, that express something important about their personal, social, or physical environment. It's important to understand that the reasons for behaviors or oftentimes beyond the disease rather than only within being the individual, which are caused by any biological or disease process. Next slide, yeah, sorry. When we say all behaviors, previous slide, please. Thank you. When we say all behaviors have meaning, it refers to all personal expressions, which could be words, gestures, or actions. All of those have meaning. These behaviors occur as a result of changes in the brain, which affects their memory, judgment, or orientation. Personal expressions communicate meanings, needs, or concerns. So therefore, the term responsive behavior is intended to focus attention on discovering the care approach that addresses the reason for the behavior. Next slide, please. There are many terms out there to describe the behaviors. Some are technical, some are medical, some are outright judgmental. We'd like to stick to responsive behaviors because it focuses attention on discovering what could be the care approach that could help address the reason for the behavior. So we are trying to figure out, it is in response to something. So what is that something that we need to figure out in order to help our clients better? Next slide, please. These are some examples of responsive behavior. So it could be wandering, screaming, hitting, turning away care efforts, grabbing onto people, repetitive questioning. And we need to understand when we are documenting responsive behaviors, it's quite key to remember a few key points. We talked about how all personal expressions have meaning and are an important means of communicating needs and concerns. So when we look beyond the framework of judgments of pathology as being the root cause of all these actions, care providers then seek a comprehensive understanding of the person and his or her expressions. So it's quite important to avoid words like aggression or exit seeking, because these words, when used in the client's care plan or notes without any additional comments about what might have been happening, for example, like needing to use the toilet, can be misleading. Lack of wholesome documentation leads to LIN and in turn long-term care facilities drawing inaccurate conclusions because they have limited objective data. So when you are describing responsive behaviors, it's critical that language used be respectful, specific, and objective in order to facilitate understanding and lead to appropriate care planning. So what's really important is for documentation to reflect the what and the why and the intervention and the outcome when responsive behaviors are encountered. We are moving on to a second poll question. So responsive behaviors are thought to be an expression of which of the following? So you can choose any of those responses in the next 10 or 15 seconds. And Ryan, you can let me know when you've had all the responses in.
Yeah, we have about half people right now. Just wait a couple more seconds. And okay, I'm going to close the file. So looks like 98% said all of the above.
Exactly. It could be due to just one factor or a combination of many factors that could lead to a particular behavior. So when we are going to look at responsive behaviors, it's important to understand that who are we working with? So who is our client population? Who are we referring to when we say BSO population? These are older adults with cognitive impairments who exhibit or at the risk of exhibiting responsive behaviors, either due to mental health, addictions, dementia, or other neurological conditions. Next slide, please. Yeah. People often ask me, why another BSO team? What do you do? What's different from you from the other teams that are out there? So I usually use this to explain, depending on where the client is the client in the community? Is the client in a retirement home? Is the client in long-term care? Or is the client in a hospital? Depending on the setting, there are different teams that help to deal with the responsive behaviors, because behaviors can occur at any location. So these are the different teams that are in HNHB LIN. And if you see in this flow chart, you can see the orange team that's been highlighted. I did that so because that's our team. We are the community team. We also have a crisis team that is in the community. So any clients that come in to us who are living in the community, we would deal. I have a team of clinicians and case managers that work alongside or work with the existing mobile crisis teams or the hospitals or the LIN, and we help in the long-term mitigation or case management or intervention for clients in during their transition to and from other care settings in collaboration with all these other BSO programs. Next slide, please. So we have developed an assessment tool for our BSO team. So the framework of assessment tool is based on risks and pieces and some models of understanding behaviors, including the unmet needs theory and the ABC models of behaviors. So the initial assessment and the ongoing visits that we would do helps us to get to the source of the behavioral symptoms. So it's a structured, goal-directed assessment which helps us to identify the underlying causes that precipitate, maintain, and exacerbate the identified behavior concerns. So the holistic assessment helps us to develop a behavior care plan and an ongoing evaluation of clinical outcomes and its effectiveness. So in this slide, if you look at PIECES, I'm sure many of you are familiar about PIECES. This is a framework for understanding the often multiple causes as to why a person behaves the way he or she does and what resources are available to build on. So the first three letters PI or PIE represent an individual's physical, intellectual, and emotional health. The S or the ES represent the environment an individual interacts with, which could be both the physical as well as emotional environment, and the person's social self, which is the cultural or spiritual aspects or their life story. Next slide, please. So when we talk of risks, it's important to identify which behavior is putting the client at the highest risk, or which is the most distressing for them or the caregivers. So this is an acronym, and as you know, healthcare, we have lots of acronyms and we're quite fond of our acronyms. But it's an easy way to remember when we are looking at risk factors. So the R is the roaming, or this is the potential for someone to wander unsafely. When we look at I, this could be the potential for harm to the client due to injury, unsafe ambulation or falls, increasing frailty, or due to illness or infection. The S could be the potential for suicidal ideation and the ability to execute a related plan. And K stands for the potential for compromised relationships with significant others, including family, friends, or formal care providers. And the S in risk stands for the potential for self-neglect, where the client could neglect his or her own care needs or put himself or herself in unsafe situations by, for example, unsafe or unlawful driving or substance abuse. Next slide, please. So again, we have a poll question. If you could answer, if it is easy to distinguish between responsive behaviors that's exhibited by a person with dementia towards their care partner versus when intimate violence occurs. I can see the INTI. Sorry for the other part of the question. I think it got cropped.
We have about half that's, we'll just wait another couple seconds. So 88% said false and 12% said true.
It's extremely difficult to discern between the two behaviors, particularly when the person has advanced dementia. Some factors to look at and assess that can throw some light whether this is coming from the dementia or is it just domestic violence that occurred in the context of intimate partner violence that Rayanne was earlier referring to, is trying to look at factors like, is there a history of domestic violence? What are the primary, secondary, and victim-focused risk factors that are occurring, and also very important to focus on the capacity of the perpetrator. So just to walk you through a case study, this is about a client who's a 75-year-old married male who's living at home, and his wife is his primary caregiver. He was a librarian by profession, and he had to quit because of the changes that the wife observed in him, and there was a diagnosis, and he was hospitalized because of a recent fall, and he was discharged home with supports from the LIN, and there's a risk of falls, and the caregiver was quite stressed because of the behaviors that were present, and some of his behaviors included wandering, pacing around inside the house, and he also attempted to go outside for walks, and whenever the wife tried to stop him, to do it, not to do it unsupervised, and that's when the client got upset and screamed at her, and he gestured as if to hit her. So we got a referral when the client presented with these symptoms. So here we can look at, once the assessment was done, this is just a sample of how the behavioral care plan can look like. And the action plans, as you can see, it can comprise of many things. The action plans in the behavioral care plan can be an intervention, or it can be an interaction, or information or education that we might provide the client or anybody who's in the caregiving situation. We put in very specific action steps without any ambiguity, without any assumptions of what others should or might know. It also pins down accountability. For example, if you see there's an action plan, there's a time frame, and there's also realistic time frames when those outcomes can be evaluated or followed up at. And this helps us to keep going in back. That's the advantage that we have as a community team. We are in there for a longer time. So we go in, we assess, we identify, we come up with this care plan, and we have these strategies, and we can keep reviewing and following up till we make sure that the client is able to continue to live in the community as long as possible, and the risks are mitigated. And again, this might reduce the need for them to having to go into a hospital or into a long-term care facility, as much as we can help them in the community with all the supports that we can bring about into the situation. Next slide, please. So when you look at this slide, so this is basically what our team does. We look at long-term support for the clients and the families. We assess their behaviors, and we develop, implement, and monitor the care plans addressing those responsive behaviors. And we also bring in other community resources and connect them with those supports that would help the client or the caregiver to deal with those behaviors and stay in the community as long as possible. Next slide, please. So our referral process is through our website, our first link referral form, and we have our team spread out over different locations. So we have a team in Hamilton, Burlington, Haldimand, Norfolk, Niagara, and Brant. And if you could go to our website, and if you wanted to refer a client, this is the referral process. And I just marked, I think, in blue, so that those are many categories that are there for all the different services that the Alzheimer's Society provides. So if somebody is looking for specific behavioral intervention, then they would want to check off the box that says BSO Behavioral Care Planning, and it will come to my team, depending on where the client is located out of. Thank you.
Thank you so much for providing some overview about the Behavioral Supports Ontario. I find the chart that you provided in terms of the different teams really enlightening, because I know we talk about BSO and a wholesome, what we don't like as a big group, but we really to understand the different groups and the different teams that are out there and the different capacities that they play, I think is really important. So thank you for that. So now we're going to turn the presentation over to the other team in Guelph. So Jody, if you wouldn't mind unmuting your phone, and then we will begin.
Okay, we're good to go over here.
Okay, go ahead.
Okay, so this is Laura talking. So I have the position of being the Seniors at Risk Clinical Consultant. This is a position that was developed really out of a need in the community because the cases that we were seeing have really increased in complexity, and we were seeing a lot of risk out there in the community. So it's a position that is under the community mental health. Sorry, I'm just going to move the
Laura, I'm just
microphone
going
closer.
to so I'm just going to ask if you could speak clearer or closer to the mic. That would be great.
Sure. Let me
That's
see.
better.
Is that any better?
That's totally better. Yes, thank you very much.
Okay. So the Seniors at Risk position is a position that is housed out of the Canadian Mental Health Association. Can people hear me better now? Is that better? Okay. Anyways, it's a position that is designed to look at people who are experiencing moderate to severe mental health issues along with cognitive impairments. Basically, what the position is it's designed to incorporate a broad range of risks. So it's not limited to abuse. Certainly, some of the referrals that I get involve abuse. So any type of abuse, including physical abuse. We've had calls about sexual abuse, emotional abuse, financial abuse, and then of course neglect. But it's also a lot broader than that. So I can get calls about other types of risk as well. So if people are declining in functioning, I get a lot of calls about hoarding. Sometimes there's a risk of poverty. A lot of the referrals that I get might be from hospitals. So if somebody is presenting to hospital, they're unknown to the system, they're presenting as disheveled, the hospital discharges them, they can put a referral into seniors at risk to go and see what's going on in that home environment. Really, the nice thing about this position is that anyone can request a consultation. So there's no referral process really, it's a direct phone call. So I would get calls from, neighbors, I get calls from family, lots of calls from police. I get calls from the LIN. Like I mentioned previously, a lot of calls from hospitals. So even if I get a call from hospital, I can actually go into the hospital and meet with a family or be part of a discharge planning case conference. A lot of the role involves consultation, so that would be a big piece of what I do. So whether it's consulting with other staff that are working in the system, so the CRBT team, whether it's intensive geriatric service workers, other social workers, LIN care coordinators, that's a big piece of the role, is providing that consultation. And in the next slide, you'll see a bit of a framework for what we use to do that. There's also a role where I can go and do joint visits. So joint visits happen, I would say, in those times where a referral comes in, there's maybe not a lot known about the senior. So I can go out and really help to give a lens around what the risk is, what services may be needed, talk about any education needs. I'll also do a joint visit. So if an individual, let's say they're already well connected with support. So if they're connected with the LIN, if they've got a CRBT worker, but there's a change and there's some risk, I can also go out and facilitate a family case conference from that perspective. So looking at informing and educating the family on what their roles and responsibilities are, if they're acting as substitute decision maker, and really having a conversation with them around the concept of reasonable risk. So we all know that there's never no risk when someone's living at home or anywhere, but it's looking at that concept of what level of risk is reasonable before we need to look at making additional steps. The other part of my role would be to look at care coordination. So as I mentioned before, sometimes with those referrals from police or from hospital, I'm often the first one in. So it's really a call that's going out to check the environment, check to see if this senior or older adult is functioning in the home. So at that point, my role becomes more to do a broad assessment and figure out who the other players are. So who is there to help support this person? Is there family involved? Does this person need the LIN to come out? Is an occupational therapy assessment needed? So that's also a big part of the role. I do sit on a consultation team that meets every other month. It's called the Elder Abuse Consultation Team. It's a great team that we have in Wellington County. It's multidisciplinary. So it's made up of a variety of healthcare professionals. So the LIN sits on it. There's a member from VON that sits on it. CRBT sits on it. But then there's other community partners as well, like Women in Crisis. There's a lawyer that attends when possible. We have police sitting on it. So the purpose of that is that anyone in the community that has a case that they want to review can bring it to that table, and we'll sit and try to problem solve it. We also are fortunate enough in our community to have the Emergency Retirement Home Placement Program. And I'll just touch on that briefly because I think that was a whole separate webinar last year. But that's a program where if I'm working with an older adult and they're at risk of abuse and it's imminent and we need to find somewhere safe for them to stay, we have an agreement with, I believe it's 5 different retirement homes in the area where we can access an emergency retirement home bed, and that cost is subsidized and paid for through Wellington County Social Services for up to 2 weeks while we can put a safety plan in place for the individual. So again, with this role, one of the nice things about it is there's no specific pathway. It's really all about when that call comes into seniors at risk, it's really finding at the front end what is needed. So I find with a lot of the cases that I have, they're very front end loaded. So it's doing a little bit of investigating to figure out what the problem is, who needs to be involved, and then what we can do to help resolve the risk issue. We, as part of Seniors at Risk as well, we do an education piece. So that can be just with, as part of a case conference. So I do provide a lot of education to families. So for example, on the roles and responsibilities of power of attorney, on the Substitute Decision Makers Act. There have been times where I've done joint presentations with police. For example, fraud is something that I see a lot of. So we'll do presentations on fraud to service providers, but we've also gone to different senior centers and done presentations there. Generally, I guess, just to sum up in a nutshell, the way I work is when I get a call, I like to name the risk. So what is it in particular that we're looking at? So, for example, is it a fall risk? Is it a wandering risk? Is it a risk of abuse? Is it a hoarding risk? Then I look at the intensity of it. So what are the consequences of that risk if it's not dealt with, if it's not resolved? I look at the probability. What is the chance of this risk occurring? And then the big issue is capacity. And that's one where I'm consulted about a lot. So as we all know, and you've mentioned earlier, people are capable of deciding or they have a right to make decisions that we wouldn't necessarily make. They have a right to live at risk. But when does that change? And what is the action that's needed? And when I look at the action, I always try to work from a least to a most intrusive kind of a timeline there. So are there things that we can do from a least intrusive perspective? Is it just a matter that maybe some education is needed? Maybe the person doesn't know what the options are. So I always make sure that people are educated. And then if the risk continues, we may need to step up the action. So is there a point where we need to involve the public guardian? Do we need to look at doing a Form 1 or a Form 2? Do we need police? Do I need to consult with the Advocacy Center for the Elderly? So anyways, that's in a nutshell what Seniors at Risk does. I'm going to pass this along now to one of my colleagues here.
Hi, this is Jody, and I'm going to talk about some of our assessment tools that we use in helping to mitigate risk and to make sure that everyone is on the same page as us and understanding. As you can appreciate, many different agencies.
So we just have you're cracking up a bit. So
okay.
There you
How's
go.
that?
Better, thank you.
That's better. So as you can appreciate, in this work, not everyone understands risk how we understand risk. We sort of have 2 assessment tools that we use. Here at CMHA, we have sort of a culture of risk management and risk.
So it's sorry to interrupt you, Jody. It's still kind of crackly. I'm not quite sure what change happened.
I'm going to sit and
there you go.
And
that's
we're not
better.
Going to change anything because then that way we can.
There, that's good. That's
I'm like standing on top of my computer. Anyway. Anyway, so basically to begin, and I'm going to start again. Sorry, guys. We at CMHA have a culture of risk management and risk mitigation. We spend a lot of time with specialized geriatric seniors at risk trying to get our community service providers in the same language. So Laura has been imperative in a lot of that work, of discussing with the community and clients that she's working with, what exactly are the risk factors? And does everyone understand the situation the same way? What is new in this behavior? What is new in this situation? And who is causing harm? So everyone, I'm sorry, I can see feedback that we still can't hear, and I'm not
Yeah,
sure what's going on.
it's sort of in and out. That's all. I'm not sure.
Okay, all right. Is that any better?
Yes.
Okay, so we use an SBAR assessment format. So situation, background, assessment, and recommendation. So that's sort of our standard one. I won't bore you with that. It's pretty much it just sort of spells out for itself how this is utilized. If we could flip to the next one. Yes, this is our baby. This is one that we really take a lot of pride in here at CMHA, because our services, specialized geriatrics and seniors at risk, do not exist in a vacuum. So we have many referral sources, as Laura had indicated. Part of those are our lateral services within CMHA. So we have relationships with Impact and Here 24/7. So what we tried to develop, as you can appreciate, we needed to have a tool to identify risks and make our recommendations and plan that would be shared across the service network. So in situations like assisting people to be admitted to hospital, assisting people through transitional times, and also most imperatively to highlight the level of risk when we're working with our community partners. So as you can see, this is a document that gets filled out specifically by our service, and this is handed off to whomever the next person or stays with us to identify risks and work through this recommendation and plan. So as you can see, we have developed a checklist and its protocol for client safety. So we document in a system called Caseworks. I'm not sure if everyone uses that platform or not, but it's really fantastic at identifying risks, concerns in the home. So any clinician in this agency can pick up that person's file and see what the issues are that are going on at home as identified by us. It also moves through, as you can see, what else have we done to support these people? So relevant education to client and care partner, assessment of family engagement, care conferencing, identification of lead partner for coordination of services and care planning. I'm not sure if you guys have experienced this in your regions, but what we've really learned through these processes is we need to sit down at these conferences and say, okay, who's the lead and how and when can we support this lead, and when is the baton handed off to the various services? So as we know, we're really trying to smooth out transitions for these folks. So this is a document that we use. We've got a lot of positive feedback on it. And like I say, it's been really, really helpful for us. So if we can go to the next slide. So safety planning. So safety planning options is problem solving in advance. And this comes from some of our work from the Safe Pathways project. So I'll just highlight on a couple of things that we consider. Kathy's going to delve into that in more detail. But safety plans are tools that can increase the safety for the care partner and family by focusing on the situation, focusing on care partner family needs and resources that are available to them, and how you would get help in a dangerous situation. And as you know, these are really important things to have because these things are fluid. As the situation changes, so do the resources, and so does the places where we access help. It's really important for safety planning in advance, best laid plans, right? Safety planning in a dangerous situation is something that we often come across. So it's things like we have basic planning strategies that roll out of this. So move to a safe room or follow your exit route. If you're still in the house, have a code word. If you feel threatened, call 911. Inform the dispatcher that your family or friend may or may not have dementia or serious mental health issues. Leave the phone off the hook. Those sorts of things. We also utilize Project Lifesaver. We also utilize the Vulnerable Persons Registry, and a big piece of our work is care partner education about this disease process, contributing factors, flags for risk, and again, highlighting safety planning. And I'll turn it over to Kathy Sturdy-Smith. Because we're moving chairs, I just want to do a sound check. Can people hear me?
Yes, that's good.
Okay, so I wanted to talk a little bit about the Safe Pathways initiative that we've had now for a few years in Guelph, Wellington. This was a grant funded by Vital and Safer Communities through the Ministry of Community Safety and Correctional Services. And the partner co-sponsors of this grant and project were the Alzheimer's Society of Waterloo Wellington, Here 24/7, which is our 24/7 addictions, mental health, and crisis service at CMHA, St. Joseph's Health Centre, Canadian Mental Health Association, and services. And we also had care partner on that group, and a person who has been involved with the senior system, Lisa Daly, for some time. So our approach to response really brings together mental health and justice, police, Crown, victim services, mental health, and other key service providers. So there were a couple of things that were developed out of that initiative that we still use. And the Safe Pathways, we really wanted to focus on supporting people with dementia who actually have an interaction with the justice system. And so the safety plan, there's one booklet that we developed, and that's the guide for safety planning. And that's what Jody just talked about, just in terms of, you know, what you can do, for what you can do in advance, basically what you can expect with changes. We talked about responsive behaviors earlier, what personality changes might you see when police do get involved, and what happens there, and then safety planning, both from the perspective of advanced planning, communication tips, and then what to do in situations. Oh, when yes, we can actually get that booklet out. We've got a second printing happening soon, but we also have taken it back to our elder abuse consultation team. It has not been revised for about several years now. So the group is, that's part of our next project, is revising that booklet. So in situations where there are high-risk behaviors have been identified, Laura talked a lot about the referral process to seniors at risk, and we really have intentionally made it easy for people to refer her for consultation and support. Now, we know sometimes that calls can be placed to police in situations where there has been perhaps unpredictable behavior, and the care partner may call the police. The police have to look at it as a domestic, and they may end up laying a charge based on the information provided. So for, you know, that means if there's a reasonable belief by them that assault has taken place, they have no choice, but they will lay a charge. So the other piece of the Safe Pathways that we're actually in the process of revising is we have another booklet that really is focuses on the process for higher risk, both higher risk prevention and then processes for post-charge, both from Laura's role as the seniors at risk, but also how the community can wrap around support for that person and their care partner. So one of the things in the post-charge intervention piece we want to identify is whether this person has had a recent specialized geriatric service assessment, or if they would benefit from follow-up or crisis mental health. The reason why we want to really look at and identify if they've had a specialized geriatric service assessment is that we have found if there's one on file,
or we can get one before the appearance in court, that may help mitigate things and look at a mental health diversion versus, the charge and, potentially even 1 day in jail. So we really are trying to work in this post-charge intervention to ensure the safety of the person with dementia and their care partner. So sometimes we are involved in supporting the care partner to determine an alternate living plan for the person, because once the person is charged and removed from the home, they can't go back right away. We include information from the primary care provider, and I think that's really important from the perspective of our approach here in Guelph Wellington. Laura works very closely with primary care, and we certainly do when it comes to charges and the post-charge intervention. We provide referrals to community support services and resource partners. We try to provide education and resources as well. So if, for example, sometimes Laura gets involved after the charge has been laid, and so she does all of these pieces that I've just talked about. But the other thing that she will help caregivers do when that person goes back into the home is just exactly what she talked about earlier. Education around the diagnosis, to help family identify flags or when behavioral changes are starting to occur. So then we can move more into prevention the next time. And again, certainly Laura's looking at both, and that's our approach with our safe pathways and with seniors at risk in Guelph Wellington. We try to prevent wherever we can. But there are times when we find out later that there's been a charge and we get involved after that charge. And we certainly try to provide follow-up support, because this is, you can imagine the distress that charges create for that person with dementia and their care partners and other family members. And so we spend a lot of time working with them to provide support. So just again want to let you know that we do have another booklet that we're currently looking at revising as an elder abuse consultation team, and that's, as I said, that's that higher risk prevention one and post-charge, focusing on processes for both. We also have, Jody talked about the high risk assessment that we use at Specialized Geriatric Service. There is another one actually floating around through the Safe Pathways project. We're going to be looking at that as an elder abuse consultation team, and whether or not the one that Jody presented is the better one to go with, whether there's a way to marry elements of both of them. But we'll be looking at both of those going forward. Probably we meet every other month, so we may have something ready to go there for the fall. So that completes the trifecta here at CMHA. Are there any questions?
I'll let people have an opportunity to post questions. I do have a couple inquiries. One, so if an older adult with responsive behaviors, let's say a wife calls the police and they charge the older, the husband, what do they take in your situation, in your jurisdiction, do they take that individual to the police station, or is there other, you talked about alternate living plan? I'd just be interested in finding out where they go, particularly if they need care needs. That's not always the maybe the appropriate place in terms of that. So I'm not sure what the process is. And then do you connect then with the BSO to make that plan in place?
Hi, so this is Laura just answering this one. So ideally, as part of the Safe Pathways, they would be brought to hospital and they'd be brought to hospital, checked out physically, so they have to be medically stable, and then likely from hospital they'd go into the emergency mental health assessment unit. It doesn't always happen, just depending on the time and the officers involved, but that's what we're trying to coach. That's the purpose of Safe Pathways.
Okay. I have a question. What was the name of the second approach that you will be looking at? The name kind of cut out when you were talking.
Oh, sorry. That's where we've got a booklet actually for providers that's going to look at high-risk prevention and post-charge processes and support. First booklet is a guide to safe planning for care partners of persons living with dementia. The second one that we're going to be looking at revising is for service providers.
Okay, and that will be available to the public when they're completed?
We'll give that a try because we will have, we'll have to figure that out actually, to be honest, because there will be printing charges and we'll just have to figure out how we can do that.
Okay, and I think this may be for Suda. How is your experience with non-English speaking families to facilitate education support or connecting with them to support groups to caregivers or for the seniors who has dementia or at risk of and risk behavior, sorry?
Yeah, that is an important concern because of the cultural factors and the language factors. It's almost like a double whammy. One, they don't understand the disease because of the cultural myths and also the expectation, the role expectations of the family having to be the one to deal with whatever comes out of the disease and the guilt and the shame. So it makes it that much more difficult. And the language barriers on top of that makes it impossible for them to access services that might be vital or important that can get them to a place of safety. So one of the things I've done in my past role was also to reach out to seniors who are from other languages and other community and South Asian community particularly, and trying to run a support group for caregivers in a language that they identify and they can speak with. And it was quite a journey because for them to demystify what the disease is about, because they have these misconceptions that this is part of normal aging. So breaking the barrier and also letting them know that there are supports out there that can be brought into their situation that can mitigate the stress that they are going to, and that they can access external support, and getting resources in languages that they could read in was another part of the challenge too. So Finding Your Way has things that I think there are more than 12 languages that they have resources in, and I was also able to get many of the brochures that the Alzheimer's Society of Canada has on caregiver stress and identifying the risk factors and dispelling the myths, and those have been translated into Tamil. That was
Great.
the community that I had success with, and it was a dream to facilitate a support group in a language, because again, that's not something that's usually done by certain cultural groups because they don't want to go outside of their family circle. So I used to facilitate a support group in Tamil for caregivers of family caregivers who are caring for somebody with dementia.
Great, thank you. We have another question for Wellington. How widespread are similar programs as in the Wellington Guelph area? So are you familiar with other jurisdictions within Ontario that have a similar setup with specialized geriatric services and a team like you have?
No.
I
That's easy. There are other
can't hear you, sorry.
There are other specialized geriatric services, but this elder seniors at risk program we have is unique to Guelph, Wellington County.
Right, and I can just say on behalf, like my knowledge with working with LWS Ontario, is that the teams similar to this are few across Ontario. So in Durham region, there is not specifically called specialized geriatric programs, but they have Durham Regional Police Officer with the Regional Municipality of Durham, which is Seniors at Risk Coordinator, Tammy Rankin, who does similar kind of work to this extent, but they don't have this similar kind of intervention team like process that all these layers that you have available, but is one thing that I think that we're striving for in terms of ensuring that there's a little bit more consistency in terms of, it varies across province, and funding, right, also plays a role. So I think that's one of the reasons why I thought this would be a great webinar to inform people about these initiatives that are happening. So is there ways that we can go back to our own areas that we're residing in and see if there's any support for that? So in saying that, the one question I have is around funding. So I know BSO is funded through the LHIN, the Ministry of Health Long-Term Care, but I know the Seniors at Risk is funded by the municipality. How is that an annualized funding, or how does that change?
So there's two different things. It's Kathy. One is the Vulnerable Seniors Lead, which is Jody, is funded by the city and City of Guelph and County of Wellington. So I think Laura talked about the fact that there are system functions and there are clinical functions to our program. So we were very fortunate several years ago to get funding from the City of Guelph and the County of Wellington, which I believe is sort of on 5-year review cycles. So we've been very successful in maintaining that. For Laura's position, what I would tell you is that several years ago, when we identified that we were seeing a lot of at-risk seniors, the Guelph Wellington Specialized Geriatric Service that I provide leadership for, it was identified in the community that we really needed to look at a clinical function in Guelph Wellington. And so I was able to go to the LHIN at that time and do a proposal to look at converting one of our specialized geriatric service mental health clinicians into a seniors at risk clinician. And the difference is, it doesn't mean that specialized geriatric service clinicians don't have people with risk, and sometimes quite high risk, on their caseloads. But having somebody dedicated to this means that we have been able to develop a quicker response. We also have a relatively unique program in Waterloo, Wellington. It's called Impact, and it's embedded mental health workers with police departments across Waterloo, Wellington. And we have seen probably a 40% increase in seniors at risk through the services that Laura provides from this Impact program alone.
Wow. So from BSO for Suda, what would how many older adults or families or caregivers would you be supporting on average? Like, what would the caseload be?
Can you hear me?
Yep.
Yeah. So are you asking per person in the staff?
No, yeah, I guess on average. Just wondering in terms of, you were just indicating, Kathy was just talking about the increase of 40% increase kind of thing. So I'm just wondering if that's a trend that's sort of happening in terms of if more people know that if there's a service there that people then access as their knowledge increases about availability, or I'm just wondering about over time, has that increased for your service delivery for both programs?
Absolutely. Yeah, absolutely. Because when I started, and we just had compiled the quarterly reports, the Q3 reports, and from the referral rates that we've had since the beginning of this year, there's been a distinct jump, I would say. Probably there were 4 to 6 referrals per month in the months of October and November, and just the last 3 months, we are averaging at around 25 to 30 referrals just per site. So absolutely, with more awareness and the outreach that our teams have been doing and connecting with other service providers and clients and caregivers, there is a specific need for our service, and the referral rates have really gone up.
Excellent. And for Guelph Wellington?
Yep. So the specialized geriatric service mental health clinicians, it's around 40. And Laura probably carries close to that as well. The important thing, I think, to understand with Laura's position is that she talked about it. Sometimes she's the only one in because there's never been any service involved with this particular person. She may go in jointly. She may also be building partnerships with other people who can then take on the lead, which frees her up to take more referrals. certainly you can imagine, we don't want to look at wait times when we're getting calls in around seniors at risk.
Mm-hmm. Right. Thank you. So I'm just going to go through the next few slides just to talk a little bit about some of the training that we have as well. But just to reiterate the fact that, if we know someone who is living in long-term care or retirement home who is experiencing, or we know that has been a victim of abuse, that it is mandatory to report that within the laws of Long-Term Care Home Act as well as the Retirement Home Act. And as our presenters quite clearly indicated, that this is around collaboration. We need to break down the silos to support the older adult with cognitive impairments as well as their caregivers to ensure that we meet their needs. And these are just some resources through the Alzheimer's Society, and they're available on their website. Written documents and online learning that's available just to increase people's education levels. And on our website, we do have a number of tools and training intervention modules, safety planning toolkit, etc., that you can access for free as well. And we do post all our prior websites on the website with the audio and the PowerPoint that you can download. Again, here's some other websites that people can access in terms of information, Finding Your Way, which is part of Alzheimer's Ontario, the Rainbow Health Ontario to support LGBTQ older adults, Indigenous perspectives for eye care, etc. So there are lots of resources out there, and we just highlighted a few of those. And as our presenters indicated, there are many community partners that we can link with, and there are many tools that we can access. So we will post, as I said, the PowerPoint presentation. If you want to talk to our presenters in more detail about their tools and that they have, please let me know or contact them directly, and they'll be able to give you that information. Just to remind people, we do have our senior safety line available for individuals that can call to get information free and confidential 24 hours a day, 7 days a week, and it is available in 150 languages. And here's just a listing of resources. I'm not going to go through each one. However, we do have the Assaulted Women's Helpline as well as a process or an agency who can help older women, and FARFO is, or not, sorry, FemAid, which is the equivalent for Francophone older adults, as well as women that are younger that can get support and information as well. And Talk for Healing for Indigenous communities, and again, the Rainbow Health Ontario is another resource as well. And then, as mentioned in the webinar, the Advocacy Centre for the Elderly as a legal resource, or the Law Society Referral Service, two great resources as well. And I know many of you are probably familiar with the Office of the Public Guardian Trustee for many older adults who may have issues around risk levels and the inability to understand or appreciate this risk of their serious situations that they're in. They may be able to advocate or assist you as a provider to navigate the system on their behalf. So we have gone through the questions. I don't see any more posted. One person just did ask about the name of the program for Guelph, Kitchener-Waterloo. And I did miss that, so I don't know if anybody knows that by hand. If not, you can connect with us by social media and on Facebook, Twitter, and LinkedIn. And we are having you'll be prompted at the end of this evaluation, or sorry, this webinar, to fill out an evaluation form. If you wouldn't mind doing that, let us know about what other topics you'd like to see us plan as we go into our next planning year. This is a great time for you to have some input into that. So I would again like to thank all of our presenters for taking the time to share their experience with us today. And if you have the answer, I guess, was impact. Sorry for, I'm just looking at the chat box. If you have any other questions, please send me an email, or you can give me a call. I'd be glad to assist you. And again, here's our website if you have any other inquiries or you want more information about our upcoming events and webinars. So thank you again. And again, this recording will be posted on our website next week. So thank you, everybody.
Thank you.